good afternoon, guys. Thank you for coming to this debrief session, which we hope to get a lot of insight into the focus groups which we ran a few months ago around the InHIP program, which is the Innovation in Healthcare Inequalities Programme. My name is Dr. Joe Chidanyika. I'm the CVD Programme Manager at the Academic Health Science Network in the northeast North Cumbria. I will go around the room to introduce yourself, guys.
Hi, Joe. My name's Idris Rashid. I'm Director of the BME Network, which is an organisation that supports ethnically diverse communities in and around Middlesbrough and the Tees Valley area.
Thanks, Idris.
I'm Katrina Jackson. I'm an advanced public health practitioner in Middlesbrough Council, part of the South Tees Public Health team.
You?
My name is Biniar Aya, and I'm a director of a community organisation called Investing in People and Culture.
I'm Shazia Noor. I'm Director for Noor Fitness, and we work with BME Women providing health and fitness and empowerment programmes in the Tees Valley area.
My name's Nusrat Ali, and I work alongside Shazia.
Thank you very much, guys. And again, just to recap, thank you very much for the access. You helped us, you granted some access to some key communities, and we've had very, very thought-provoking sessions. We had 7 sessions which we did with about 45 participants. So today is just about sharing the findings that we got from the behavioral insights which we had. And then you guys as community leaders, as commissioners, as leaders in health, we just want to share those findings with you, and you can share your thoughts. And the whole idea really is to do exactly what we said at the start. Do this behavioral insight, learn from what communities really need, and then act on it. We might not have the actions as in the finance or the manpower to do it, but the whole idea is to have the innovations that come from you guys, then work together as a community to see how we can put that into action. So what I've got, I know we've shared this before, it's just a slide deck which goes through what we found. And after I quickly go through the slide deck, then we can go into that discussion in terms of what are your thoughts about the findings, and then next steps, which really matter, what we need to do about it. And again, in the same breath, how do we feed back all these findings to the communities that share their time with us? So that's just as a preemptive slide, is the team that made this happen from our side of things. So Northeast North Cumbria, HSN, Newcastle University, and Middlesbrough Council Public Health, where Katrina and Idris are from. That's just the background again, and I've shared this before. Why we're doing this project is nationally funded. It's about co-designing interventions. It's also about targeting those 5 clinical areas in the core 20+5 areas, and our focus is obviously on CVD. And the last bullet point is very clear there. It's about co-designing the approach to CVD uptake or CVD prevention uptake in Middlesbrough, and all those listed core partners, including Middlesbrough Council. The context is very clear. You guys know it better than I in terms of why we need to tackle health inequalities. There is a reality there that there is inequalities that have not been tackled for years for underserved groups. What we need really is more than equality, it's more than equity, it's about justice. It's really taking those barriers. So we hopefully, by sharing the barriers that we shared by your communities, we can then make those interventions stick and really make it fit for practice. We've mentioned about core 20+5, so working with our ICBs, integrated care boards, it's very important that we focus on CVD, case finding, and lipid optimization. Again, the backdrop when we discuss this in detail with your communities, why CVD matters. It causes those deaths every minute or every 3 minutes, a lot of hospital admissions. And for the context of this really, CVD is the biggest killer in the UK worldwide. We use this behavioral insight approach to do this research, but actually all those 8 or 9 areas also have used it before, and I'm really, I've worked with a lot of you guys in different work areas there Katrina in public health, Idris, all of you guys, it's very much applicable to any settings that we would want to work on, and really working with the council helps to actually articulate this, getting closer to the communities that need to be served better. So going on to the project itself, thank you again, you guys. You did make this happen. We worked with all those 4 areas, 4 communities: South Asian women, the underserved white community through the Thorntree Community Hub. We've also worked with Idris around the South Asian and African community, and we've also engaged with Bini around the migrant communities, in particular some professionals within the migrant community and some asylum seekers and migrants who shared their views. The aim, as you know, this is really good background context which we use throughout the interviews. It's really more than just looking at identifying the barriers and challenges, because you guys have articulated this now and again. Every single consultation you've articulated this, but we wanted to make it personal to Middlesbrough. Although this will be used nationally, we wanted to make it personal to say what are the barriers, what are the challenges in Middlesbrough, but then go on to co-design those potential solutions, which is where we are now. We're feeding back and we're trying to co-design what are the right solutions from the findings we got. But I think the next 2 steps are very important. How do we then pilot those solutions? What do you guys feel is fit for practice to then enact those and improve uptake of CVD prevention strategies? But beyond that, there's about 42 different projects in InHIP nationally. Beyond that, we want to share those learnings nationally. So we know that deprivation or innovation which is done here in Middlesbrough is not dissimilar to other parts of England. And we've got a really good opportunity here to share what we found here nationally. So I think those broadly are our key aims. Without going into detail, we did meet with 7 focus groups. We did interview 45 participants, which you kindly offered access to. And again, the 3 target communities for this project was around the South Asian, Black African, and white underserved population groups. And I won't go through all the numbers which we were in each community, but we've got a slide deck to always share with communities. Project delivery, we had to define the outcome. What is it that we wanted to achieve? So we wanted to achieve increased uptake of CVD overall, but we also wanted to increase the knowledge about CVD as a condition, look at the barriers, but actually how do we sustain the interventions which we're proposing? And the context, again, we know that Middlesbrough is one of the most deprived areas in England. We know there's poor uptake for health check. And we'll come to the matter of health check, because we in this project, it was more of not the mandated NHS health check, it was CVD health checks, as per se. But we do know, talking to you all, that there was good engagement during COVID, when people were being vaccinated. So there's something that you guys have done quite well to get to the communities that needed it most. So I think this is a combination of the learning that was shared and where we need to be. And as I've said, we've used behavioral insight, in particular the EAST framework, which I'll come up to really understand what people want and how we can get there. And briefly, that is the EAST framework which we articulated in our research. So how easy is it for people to access CVD prevention? How attractive is CVD prevention as well as a core public health area? But from a social perspective, what are the roles and responsibilities of your communities? But most importantly, if we know what to provide within your communities, how timely is these interventions? Are they going to change the behavior which we're seeking? So I think we did take a systematic approach in trying to understand the feedback from your communities. In terms of behavioral insights, what were the challenges for us? these were the clear challenges in any behavioral insights or qualitative research. Can we engage the communities? Yes, we did. You facilitated that access. Can we engage the commissioners? We've got the likes of Katrina and Idris here. Can we engage the actual target population? Yes, we are. We know that for qualitative research, it's hard to be representative, but we've reached out to the target audience. And again, there's issues around our findings, how they impact, you commissioners in terms of delivering the services. And we still very much engage with the PCNs who also have got a vested interest in how this would progress. So I've shared the report with you in terms of the themes that came out. You would agree, or we come when we discuss the findings, from how easy it was to attend the health checks. What we got from your communities was that GP appointments were the issue. And we've had this before. But, there's some examples there when someone rings 45 times to just get an appointment. And after that, they're told there's no appointment. So you have to wait another day, another week. So clearly, GP appointments was an issue. Language barrier, this is not only in Middlesbrough, but we know this is now very ethnically diverse. Am I right, Katrina? Is it more than 13% of people?
I'm not certain of the figures, but yeah, we're up there.
We're up there, BME population. Yeah. So it's a very significant population mix in Middlesbrough. The wait times, again, nothing rocket science about it. Some investigations or through our focus group, people were waiting for 6 months for an appointment. And one particular lady, because they wanted a person who is from their gender, they'd worked for a year and a half just for an appointment. So it is real. This is the practical stuff that we found from your communities. But there was some solutions there. People were talking about convenience. Why shouldn't they go into a GP practice and ask for an appointment? And we know years ago we used to be able to do this. But again, health literacy was a point which was articulated. And this is not just because people cannot speak English. For people who do speak English, if you talk about jargon, that really cuts out a lot of people in terms of their contribution to their own healthcare. But also we have to take mindful, I thought we had a very clear voice as an example from the taxi drivers really. Say their occupations gave them a disadvantage, unsociable working hours, the time they need to access services. So all that really prevented people from accessing health checks. And we talk about, is it attractive to prevent CVD health, the CVD condition? Yes, people prioritize that, but there were so many issues which were affecting them. Again, I won't go through everything that we've got in the report, but things like staff attitude. You ring up and you think that there's a gatekeeper you can't go through. But as an example, the receptionists are doing exactly what they have to do. They have to ask, why are you calling? And you can't see this person for availability. But it was perceived in other areas that they just couldn't go past through the receptionist. There were issues about their conditions or their feelings or what they want to be seen for being dismissed. So that dismissive culture. But again, some didn't think that they had a say in their health. So that shared decision element was articulated. And a new concept for me was around prognostication. This is when someone thinks, you know what, this is terminal for me. I'd rather not know that I've got CVD, I will have a heart attack. And obviously postponing that was clearly what is to lack of CVD prevention uptake. But discrimination was also factored in, perceived discrimination to say, I'm not getting the service maybe because of the background that I've got, whether I'm an asylum seeker or whether I'm from an ethnic minority group. These were the voices heard. But again, even for the ethnic white communities, they felt that they were not being served. So that element about being underserved was discussed quite a lot. From a social aspect, again, I mentioned about undeserving. Some of the communities, regardless of race, they think, well, I'm a burden to the system. I don't need to phone my GP. And clearly, they need a check within. within the time scale. But there's a lot of questions we were asked. We tried to address some of them. What is a health check? Because people ended up thinking having a blood pressure checked is a health check, or just cholesterol. But we know a health check is wider than that. It's getting all those elements checked. But solutions were there within the community. They want services to come closer to them. And they say we are branded as seldom had or underserved, but we go on the same bus routes. We go on the same shops where everyone shops. So that element of bringing services closer to the people was mentioned about. And what we're doing today is important because they thought that sometimes the tokenistic engagement, we go out, we consult, we go away, we get our research, but they were saying what comes out of this research, we want to make an input in that. But ultimately, everyone was receptive to change their behavior as long as they get the information that they needed. And the last one on the East framework was around timeliness. So we all think that NHS is free, but people were saying, it costs me. I can take 2 buses to go and see my GP, but if I don't have to go on 2 buses and buy a loaf of bread, I don't have to. And again, there was that perception around health ownership that people don't prioritize their health, which was the opposite. People care about their health, but because they've got different priorities, doesn't mean that they shouldn't get served. Solutions were very clear. They were preferring, some of them, walk-in appointments. Some were saying use social media. I've had a new suggestion there around why don't we use WhatsApp, to get appointments, GP practices. Everyone uses WhatsApp. It's a new idea. But again, the challenge, and maybe labeled towards yourself, Katrina, about do we need to amend the health check inclusion criteria? Yes, we've got a mandated service, but they were saying people in other ethnic communities get heart attacks earlier than 40. So do we need to change who we target, whether it's mini health checks or whatever is there? It was quite helpful to know from their perspective. And again, those were the themes that we've just gone through. But learning from that from us as a mutual partner in this is how do we then change that behavior? And this approach for me, the Cumbria approach, is really helpful. So from a personal perspective, what is the capability of that person to accept or their psychological or physical capacity to engage with the service? So we need to look at language, health literacy, parity of esteem, as in people with mental health and learning disabilities. They need more help to access these services, regardless of their race and gender. What are the opportunities which are there in terms of factors that influence that individual to change their behavior? So if we tackle discrimination, if we tackle service access, if we tackle social economic factors, where can we be? If we improve cultural competence, where can those people be? But motivation becomes a personal factor as well in terms of what is that person's own energy to engage with services. So they were talking about social mobility and social capital, that they've got the resources in their communities to do this. Social prescribing, which is a popular concept in public health. But I know some of the community networks that you run, or health champions that you run, Katrina, a lot of reflection around, we've got community champions, we've got community leaders. Let's tap into that resource. But all in all, the central part is that behavior change. How can that influence uptake of health checks? And in our discussion which follows, we will look at this around the key barriers. So we've talked about the staff attitudes, clarity of what is a health check, cultural competence, health literacy, all that. I think those were the key barriers that were articulated by the communities. But at the same time, they came up with solutions to say, translation is important as an example, but how accurate is that translation? I know in my mother tongue, if you tell me someone then to say, what is heart attack? It would be very difficult for them to say in a concise way. So translation needs to be accurate. That's what we had. Social marketing is an enabler in any guise. Health champions. So some of the solutions which are there are not rocket science, but clearly more of the same is not getting where we need to be. A lot of people are still not getting their health checked. So clearly the enablers are there, and we'll probably home down on this slide when we do our discussion in terms of what are the solutions. From us then, as a neutral partner, the implications of practice are very clear. There needs to be more raising of awareness in terms of what CVD, where the services are, who access them, how should they be delivered. But we are very clear, we need to co-design these interventions. One head or, one approach will not fit every of our communities, but we need to be seen to have those variety of options available for our communities. But what is then important is about testing and, how that can be delivered within the real life setting as well. And the last slide for me really divides the two. Yes, we've got the mutual need to improve uptake of health checks, but we always need to remind ourselves around what are those barriers in terms of capability, opportunity, and motivation, and what are those enablers. So from what we've learned from the research, I think the answer lies within this slide deck where we've brought together what was said from the communities, but we can't preempt what needs to happen. And I think this is, we set the scene, we know what communities want, and we are more than happy now to set that discussion with you guys, because I think you are closer to the population you serve, but probably can articulate that voice or that need for empowerment better than one single voice within those communities. So maybe the first thing would be, are there any stark reflections on what we've just said? Is there anything that is probably jumps out for you guys, or this is really much what your bread and butter, what you feel has been happening for a few years?
For me, there's no major surprises. It's a little bit sad and a bit frustrating that some of the old issues are still there, like language and access and lack of knowledge. So that's a little bit frustrating. But no major surprises. But I just think it's great that the people that you've had involved haven't just come up with the barriers, but have said, why don't we use this and why don't we do that? And that's half the battle, because actually that's your first step towards co-design, isn't it? So no major shocks, just a bit disappointing really that this is still the situation we're in really with health checks, for me anyway.
No, I think it's quite a helpful reflection, especially coming from a commissioner background. I think any reflections before we go into the meat of the discussions? Shazia, I can see you nodding your head.
No, I was going to just say the same thing, but also the fact that it's kind of good for us to see from Noor Fitness's perspective, the women are kind of more motivated, and they're saying well, why don't we do this? Why don't we do that? Whereas when we started 10 years ago, you wouldn't have got that.
Yeah.
There was there was a barrier there all the time. Whereas you can see now that there is a little bit of a change where the community is wanting to, contribute and do something, and that's really good to see.
Excellent.
I think first impressions, looking at the findings, I don't see anything obvious that jumps out. I think a lot of that work within the grassroots communities hear and see the barriers on a daily basis, and I think it's good that you've collated that information, and hopefully we can build up on this research and address some of those.
That's a helpful reflection as well, thank you.
Just to quickly add on, for example, one of the suggestions that was made in terms of communication, WhatsApp. I mean, I would not have thought that is a hugely costly communication means. Airlines use it. Doctors in, I, for example, had to communicate a heart surgery for someone from Ethiopia and Turkey. And all the time, I was communicating with the private clinics on WhatsApp. It was simply made so easy for them to communicate cross-continent. And just assuming that everyone has access to email, their laptop, have a mobile that is perhaps traditional way of using it. But as a charity, we communicate by WhatsApp all the time. And we are a very tiny charity. And I think there is a scope for the NHS to change. Maybe. So that is a suggestion that came from the prospective clients or customers or patients, whatever.
No,
And I think that's really very innovative.
And practical.
And it's a very practical, and it does work for other services. So there is no reason why it shouldn't work for health checks.
So that's helpful. I think in our next discussion points, we'll home down on the barriers, and we can unpick that. But it's a very good first reflection of what you think, what transpired, because I know you were also part of some of the focus group. And so before I go into those barriers and enablers, Nusrat, I know you're part of one, actually, the two focus groups for the women as well. What is your reflection? Because this is now coming from everyone, how do you see this laid out? Does it reflect what you've come across?
Yeah, it's basically, I think, frustration of how they get information sent to them and how sometimes they don't even know that there is checks out there, and it gets missed, so they don't even know half the time.
That's right. Yeah, that was evident in a few of the focus groups where if someone is between 40 and 74, they should get an automatic invite, isn't it? But if they fall out of that age group, for example, which we are advocating for CVD health check, some people had never been invited. Or if they're invited, they never knew that they're entitled to be checked annually for that. So it's a really
Going
good...
back to what Bini said about WhatsApp, I'm just laughing because most of the aunties and uncles are on WhatsApp.
And
My
that's a
dad
target group.
is on WhatsApp. My dad wouldn't even use a smartphone. And when we got him and it would ring and he'd be like this trying to slide it. And here, I'm not using it. He didn't use it. He was like angry with them for why you got me it. Then when he did turn over to it, now you get a message on all the groups from him, and then he sends a good morning message like a prayer or something to every single one of his contacts and all the groups. He sits there and sends that message every morning.
At your fingertips, isn't it?
Yeah.
So you're right, it's about that innovation to get to...
That's one way of getting information.
It's being confident with it. You've got that confidence that you trust the messages, to send them, and you trust the messages that are coming back. It's half the battle, isn't it?
Is there any of those that you think, before we go to enablers to say, how do we tackle it, is there any of those barriers that you really want to articulate, that you feel your communities are more affected by? Because this really came out from across the board, all the three target communities,
I think when you're looking at key barriers, health literacy jumps out to me.
Okay.
I think a lot of people don't associate lifestyle, diet, and how that is linked with cardiovascular disease. And I think the more work we can do upstream in terms of addressing people's lifestyles, diet, and I think the better outcomes we can achieve. And I think the most of the work needs to be done upstream on CVD.
And I take that point, upstream. Upstream, that is the key public health term, I would say, because clearly that is a barrier if people are not even looked into what you need to do, the lifestyle, the public health messages. So, no, it's really...
Can I slightly look at the other side, though?
Yep.
Because mine is more about, you can call it health discrimination or cultural competency. I think it sort of overlaps. When people go for a certain health issue, and if they had a bad experience with that receptionist or with that doctor, or if they have had almost a nightmare to try and get that appointment, I think the last time that they would like to go to is that same place. So it is, I think awareness is so important, like Idris said, people need to start living healthy and do all of that. But if it is not a place that you really feel are not welcomed and you have to work extremely hard to try and get an attention or have been bounced back a few times, then when your heart check comes, or if they have, if you get to become aware and you think that you are due to do your heart check, if that first experience for other health issue has not been great, then you are most likely, and this is the common human behavior. I don't think that is related to health.
Okay.
You know, if I catch the bus to go to Newcastle and I had a really terrible experience going to purchase my ticket, or if it is so complicated, or if there are people that I don't really like who jump into that bus, I'm more likely to either not go or catch a train. So I think that's the other side of what Idris said.
And that word is powerful, isn't it, in terms of if you get a good experience, you share it, people are most likely to receive this. So it is, and it jumped out in some of the conversations which we had to say, you know, those community champions, or what we say, the community leaders, can be powerful in getting that word out, but it needs to be always be, you know, maybe coming from a place where those issues have been resolved and you know that you're promoting a service that can, you know, it can be positive. So you're going to say something.
We've had that so many times. We've had women coming in and saying to us, when we've said, look, in classes we'll tell them about, because a lot in our community, cardiovascular disease, there's no interpretation for it even. You'd have to say heart, or you have to use a different name, for example, same as diabetes. And when we try to motivate them, they'll come back and say, yeah, but this is what happened and this is what she did, and you know, they were rude to me, they were this to me. So then it's our job to kind of like say, look, we understand that.
Correct.
And then we have to speak to them and motivate them to go back in. And really, you think, you know, what if we weren't then, or why should we're happy to do it, but that's not our role to do.
Correct.
If you know what I mean. That first experience should have been good for them to want to go back. And sometimes, like, we've known women who, there was one lady who had a lump and she never went. But when she attended one of our classes, when we were doing a talk about breast cancer, it was also motivated to go in. And she's here now, so many years on. And you think, well, what would have happened if she hadn't gone in?
Absolutely,
Scary.
absolutely. And that's where, and Katrina will agree with me, public health has got so many touch points, and that's when we talk about making every contact count. And that contact has to count, because if it's a negative experience, it can rub on to others. Is there
It's
anything
got to come
else?
from a trusted source as well, you know, to really sort of resonate with the people you're speaking to. I do think, back to basics, the CVD reference, it's, you know, it's, when we used to do checks in communities years ago, we just call them a healthy heart check, because, you know, CVD sounds a bit clinical and maybe a bit scary, and you know, it's so even some of the basic terms that we use, and you know, the descriptions of what a health check is, let's not speak in clinical language, let's speak in really basic language, let's keep it simple.
That came out so
scary.
strongly. Yeah, that came out so strongly, because we're coming from a medical or biomedical model, and there's nothing wrong with it, because it is a medical condition, but it's how then it's reflected and how people can be engaged without making it too medical. Yeah, we've talked about health literacy there and cultural competence. I do not know how much you've read about some of the stuff that we're talking about, and we don't necessarily want to ignore it, because sometimes it might be perceived discrimination, but there was that really strong voice that came up to say, well, I've phoned up so many times, and maybe it's a technical issue that there's no appointment, but if someone is rung 45 times, what I heard was, I'm not getting an appointment. Why? Is everyone else feeling or getting treated the same way I am? But if it is a system issue which is addressed, we need to probably have that message across to say, actually, the undercurrent is capacity rather than that. But there was a very strong perception to say, there was one saying we said, you need your foot on the ladder. So if your foot is not on the ladder, how can you access the health that you need? So that came up quite strongly.
I think GP appointments and waiting times is something we're not in a position to resolve, unfortunately, but it's got to be, we know it's an issue on any health topic, and this has just sort of confirmed it again through this, but it's a nationwide issue, isn't it, the GP appointments and the systems that are in place. I know there's talk somehow about improving that 8 o'clock dash for the phone, but that's work behind the scenes. Obviously, we aren't involved in as a public health team, but
so if we flip it on the side, because some of that, we were talking about those barriers, so the enablers would probably be some of the solutions the community suggests. And picking on your point, around 8 o'clock, phoning times, there was a suggestion from some of the women-only group who were actually saying, yes, there's that mad rush to phone at 8 o'clock, but I need to take my child.
Yeah.
Yeah.
But at the same time, they're saying, why then could we not have an afternoon phone-in session? So for those who want the morning sessions, phone in the morning. The afternoon, likewise. So there was that recognition to say there's pressure in the system, we understand that. And just to preempt one point, then many people, not only from the women-only group, I have actually, it was a strong voice from the underserved white community to say, I'd rather walk in to the A&E to be seen for something the GP would have seen me, but I'll be seen at least that day. Never mind that I'll wait for 4 hours.
And someone
Imagine.
say,
Yeah.
to see a dinosaur in Albert Park.
Yes, that was a classic quote to say you're more likely to see a dinosaur in Albert Park than getting a GP appointment. But that was a strong sentiment from an 86-year-old gentleman who sat there and said, well, I've lived in Middlesbrough all my life, and I cannot now get an appointment. So those were some of the key enablers which were put in there. I know social marketing sounds a very technical term, but I think what people were coming out there were actually saying, not only talking about WhatsApp to say, where do we need to be promoting these services? Where are the people? And one group, which was the report, the doctors who from a migrant background, they were saying, for example, in Poland or in Ukraine, we do get a lot of these messages. If I go to a car garage, getting my car fixed, I'll be told when to go for my health check. So those are some of the places where we don't advertise. We've got partners who are outside of health, but they were coming up with solutions to say it needs to go further than this. Some of them were saying, I spend my day watching Sky News, but nothing comes out on Sky News, as an example. So they were going beyond what we always think are the avenues. So I don't know if there are any key enablers which you're happy to discuss more about?
We found like using different avenues, for example, like you said, shops, clothes shops, the women go to. A lot of the women that come to us, they go to Arabic classes and they go to learn. And that's like a key place where there's God knows how many women go in a week, which are not utilised sometimes. And again, going back, we have this perception in Islam, whatever's meant to be is meant to be.
Yeah.
So a lot of the time, one of the barriers that we get is, well, why do I need to do this? Because if that's my time, that's my time. So someone like an Islamic teacher who's teaching you something explains to you, well, actually, whatever's meant to be is meant to be, but you also have this, responsibility of taking care of your health because your body is a gift from Allah. So when you get someone like that telling the group that, you'll find that you're going to have a better momentum. So we utilise that a lot, don't we? Like we will call them and say, look, we want this doing, or we need you to convince women to do this and that. We've got a focus group on Thursday, and we've chose one of the leaders to come. And I just feel sometimes like you get such a huge impact from there that we kind of missing really. And I'm sure there's other communities who have similar places that people go to.
And that was actually resounding from many communities to say actually, and that's when they were saying in their own words, community assets, we are the assets, and we can facilitate and enable that. So no, that's it really echoes what we found in the research.
I think taking some of the learning from COVID and using that sort of asset-based approach and, using community centres like this, the mosques, the faith venues as an asset and using those partners to get some of the key messages out, but also utilising those venues to offer, healthy heart checks, for example. And then it's having that sort of connection, that link to have those sort of trusted voices there as well.
And I think it echoes what Katrina was saying, that it doesn't become that medical model to say you're actually going to see someone with a white coat in a clinical setting, isn't it? It's closer to you. And mostly powered by the volunteers of the local community, isn't it?
Yeah. And I think it might be, sometimes we, taking again COVID as an example, some of the COVID vaccine sessions we had would be queues out of the door. Some we put on as things started calming down a little bit. We'd have 6 or 7 people turn up and it was put on as a COVID vaccine session. And that's the thing with sort of community interventions. You need to be a little bit clever and actually just tie into activities that are already happening. So say ladies are turning up for a language session, start half an hour early with your health checks or half an hour at the end or during. jump onto a really busy knit and natter session in Thorntree with a health check, because if you put something on this specifically, again, what's people's motivation to get there? But if it's tying in with something that's really popular in that community venue anyway, that might be the way to start. And then as that reputation builds, maybe you could put them on separately as a health afternoon, you know, with various offers. But it is, you know, you've got to be a bit clever about it, how you market it. You've got to, if you were selling a business, you'd be really clever about how you marketed it. If you were trying to do it for profit, you'd make sure there was something attractive to get people there.
Exactly, and that's coming back to that idea about East Framework. How attractive do we make it in how we market? And I not only talking about the migrant community, but there's a big voice around translation to say, I think one quote there was saying, in our community, I think it was the South Asian, said actually translation means that I'll have to double up the time I have to spend with the doctor. So the translator has to say what the condition is, make sure that's an accurate reflection of what needs the doctor needs, and the interpretation from the clinical side and how it gets. So I think translation was really mentioned there, but I know you guys have always provided the services that in some of our resources were actually translated from our project here. How do you think this can be bolstered in terms of translation? Is it working well? Do we need to tweak how the translation services work and articulate this better?
I just wanted to say one thing to add on what Shaz said earlier on about using faith leaders, because you know, certain members of the community who are religious, they look up to them. So in response to, it will be what it will be. So I don't really need to make any other effort. If I had to go, then I will go, sort of thing. So by getting a counter response to that, but that counter response is coming from someone who is almost legitimately have the right to respond to it, i.e. religious leader. That made me to think most of the health concerns and issues in my country is liaised with sport.
Okay.
And cycling is the biggest sport. So if you say something with a footballer, no one would listen because it's not the national thing. So many of the retired cyclists of certain age, they really give their time to the NHS, equivalent to NHS in my home country. And a lot of people relate to their messages because they were healthy. They know what they're talking about, so it gives them that legitimacy.
And then they're role models.
They are role models. So I'm trying to think maybe some people who look up to individuals, either it could be celebrity. I don't know. How you bring them on board, I do not know. But could it be a different way of social marketing?
That's
a thing.
That's a very good point. Because we are working with Middlesbrough Football Club as an example.
For example.
And we were having a social marketing company who are willing to come in that space and articulate the message which we want here. And as an example, they did it with rugby, articulated around cancer prevention through rugby. They want to do it through football, because Middlesbrough Football Club, as an example, is a very big trusted partner locally here. So I think if I move on to one of the next key questions, which really drill down on what we need as an intervention, it was around, there was a very, very direct point made around cultural appropriate services, whether it's gender appropriate services, whether there's cultural competence. How do you see us tackling this cultural competence? Because I know 10 years ago, we were still talking about cultural competence. And especially that the community is more ethnically diverse, we cannot necessarily translate everything into every language. But how do you think this, because all partners really clearly articulated this around cultural competence. How do you think, as a solution, how can we focus on this?
I think more than I think it's important that we have timely and accurate information for people to take away. But more than that, I think what really connects with people is people's stories. And if you can identify individuals, whether it's CVD, cancer, whatever health intervention you're looking at, and make that individual's story resonate with the wider community. And we had a lady who sadly passed away due to cancer, Nina, who worked with us in a lot of communities. And I think a lot of people on the back of that death are reflecting about cancer and about appointments and things like that. So I think, certain things happen within the community. And I think it's about utilising those opportunities or that sentiment to get information out. In terms of from looking at it from a cultural perspective, I think it's important that when you're offering services for women, for example, that you look at from a cultural perspective in terms of the timing of that service, the location of that service, and the staffing that is available. And I know when we were doing the COVID vaccination, we had the female clinicians there during those sessions, and a lot of women that didn't from the South Asian and the Muslim communities. They were positive about that. So
I think there's an issue there, because I think you're completely right, but I think, how do we let the clinicians understand those cultural issues? Because it's not one size fits all.
No.
And it's actually using the opportunity you've got now after this research to engage with GPs and people who are providing any form of sort of community health checks to say, these are real issues that you need to address, because although you guys will know what is most appropriate, some of those clinicians will be a bit ignorant to it, and it perhaps actually just need informing. There might be things they've never thought of before. Oh, we could do that. We didn't think it'd be an issue. But if it is an issue, we can address it. So it's how do we get into those clinical arenas to say you really need to change your services, because that is a major barrier. There might be some things that they just haven't considered that they might be able to change quite simply if they had the right information and clarity from the experts.
Absolutely, and this is helpful because I think it's reflecting what was said as well, and I think it moves us to the next discussion point around one big suggestion which constantly came out around community outreach. They were not suggesting that they will not attend the traditional services, but they were saying, in a way, community outreach can actually free up capacity. Yeah. So if there are people who are being seen within closer to home, it means that maybe there's more appointments for other services. But how do we, or do you guys as a group, look at that outreach? Because there's so many different models. We've spoken to Middlesbrough Football Club around using the community buses as an example. But we know that through this research, someone was saying that, well, when there was cervical screening in a bus, although it was appropriate closer to us, I know he came out from the women's group only, said some people would not want to go on the bus because they'd be seen, So we still need to be quite sensitive in terms of the outreach. But as a positive theme, as an enabler, how would you see community outreach? How can that be helpful, closer to the people, and improve uptake? Because remember, what we're looking up here is how would we increase the footfall for CVD health checks? And this is not just for the 40 to 74, but this is for the worried well. This is for people who've never had a health check. This is for people who are 22 years old, who've got a family history of CVD. Yeah. So all those, but the community outreach, yes? No.
So the perspective they have is if they're walking and they're okay and they find that there's nothing wrong with them.
Yeah.
So even if you say, oh, look, like you're overweight and you need to go and I've never been to doctors all my life, I'm fine, I'm walking about, nothing's wrong with me, then one day they drop.
Correct.
We've had one this morning, I don't know if you know, a death this morning, I've heard. He's fine, and apparently he slipped, and they're saying he's had a heart attack. So it's fine, there's nothing wrong with him, so God knows what was wrong with him. But it's like that, they won't go because they think, so what is it that can you be walking and be okay and still have...
And it's a very big point which you said, because most of them were saying they agree that CVD is a silent killer. But it's coming from what you're saying. If you think you're fit and healthy, right weight, maybe you smoked and never had anything with cancer. But they were saying, if you never checked, you would not know. But so the question is, how can outreach actually encourage everyone to then get those checks.
So like we sometimes have, don't we, because we do a lot of work with Northern Cancer Alliance, so we'll have like them coming in, set up a stall. So we'll choose our busiest day of the week. So if you've got, for example, we'll have, let's say, childcare course on, sewing course on, a fitness class on. So we know that's our busy day. So we'll email and say, look, this is our busy day, come in today. So then they will come in, but from walking in, nobody will know why the women have come in.
Yeah.
They think they've just come to a fitness class or they've just come to a course. So there's no stigma. And it's this thing about keeping things very private, which you can understand because I'll give you an example. A couple of weeks ago, you know, somebody passed away, but before the family even got to the home, the whole house was surrounded by other people. And that can be quite hard for that family because they haven't even had a chance to speak to each other. Because there's a lot of love in that, the fact that people care so much, and that's lovely. But at the same time, you know, you need to give people that time to settle in. So because of that reason, a lot of people, they don't want anyone to know what's happening with them. There's a lot of things where people like to keep things private. So they won't walk into like an obvious bus because everyone will know, why did she go in there? What was she doing? Does she think she's got cancer? Oh, and then next thing you know, she's already got cancer. But she just walked into a bus. That's all it was. So if she's walked into a class, there's so much happening in there. You don't know what she's gone in for. She could have gone to do sewing. She could have gone to do fitness. And then obviously, and you know, they've come in and then they've accessed something like, for example, the cancer screening. They access that. And then what we found, the other advantage is when they've come in, for example, we have loads of different ethnicities coming in. For the Arabic women, for example, like when we did the stall for them, they didn't understand anything. So luckily, there was a girl there who translated everything. So straight away, I remember thinking, what if she hadn't been there? So now I know if that group's in today to make sure that I've got an interpreter there.
Absolutely.
And first, they were all dead quiet. As soon as that girl interpreted, the questions didn't stop. To the point we were like thinking, oh my God, this is so good. Because they were so like interacting so well. But at first, everybody was like, yes. Yes.
But is that what we're talking about, the behavior change approach? If the opportunity is presented, people would open up.
Like a lot of the time you'll find in our community, if you were to meet and you were going to speak to them, they're so polite, they'll say, yes, we understand. And my mum does it, but she doesn't.
Correct.
She hasn't understood anything.
Correct.
And then I'll walk away and Mum, but you didn't understand that. But she just said yes. But we know that. So, where, for example, when we used to do the New Life News screening, let's say if someone else did it and we used to come and say, no, you didn't understand what you just said. Let me ask the same question. And then they'd be like, oh, no, actually, we don't do that.
Correct.
And sometimes what you find in the communities is they feel like they need to say yes or they need to be good.
Yes.
Or they won't be heard,
Or they won't be heard, or they need to like show to you that, no, I am doing that, but they're not doing it.
So that compliance kind of,
We can be a little bit cheeky and say, no, you're not.
Yeah.
Do you understand? But we can get away with that.
But you're in this space to challenge, isn't it? It's,
Then sometimes if they've heard it and understood and found some information, word by mouth is very strong. They will go out and spread it.
It
I
came
went
out of
there
that
and I found that helpful and do this, and it's like that.
I've had Nude Fitness for 11 years now, and if you said to me how I market, WhatsApp or word of mouth?
Word of mouth.
Till this day. I make a poster because I have to. That's me being honest.
So you've touched on the next point here, and we're getting to the crux of, towards the crux of some of the issues. Public awareness. Every focus group which I spoke to, they say, we need more awareness. So to me, it's a very strong enabler for us. And again, we use that technical term, social marketing. We all know that it's public awareness. So how can we best address that? And I know one solution won't fit every community, but clearly we need to raise that awareness. And bouncing from what you've just said there, how can we then use those community assets to raise that awareness? How do we need to do it?
For us, just talking about the women that we work with in the South Asian community that we work with, our marketing tools are like the women themselves.
Correct.
So you kind of understand that community, you understand how the families are. And so, for example, if I'm going to spread a message, I'll choose, for example, one girl from one big family. I don't know how to kind of, like when you have different big families, don't you? So, if I tell that girl, she will pass that on to all of her family.
And you trust that.
Therese, how do I explain that? Kanda, help me out.
Clan.
Clan.
So like each family clans, so you might have a group of
Extended
families.
family. So that one person will give it to the whole clan, their clan, then I'll pass it on to somebody else, then we'll use WhatsApp.
But mostly what you've done is she'll do like videos
they make a big difference,
And-
especially when I speak in the mother tongue.
And,
So, like-
and it's interesting what you're saying, because that came out from one of the groups, and they were saying an African proverb to say, educate a girl, they'll feed the whole village. So it's about that trusted person
Yeah,
who can
you
then
see her
articulate.
videos,
Yeah.
her talk, it'll go on Insta, it'll go on WhatsApp, it'll go on a Snap, and then someone's probably going through whatever whatever topic it is that we want them to come out for, or whatever it is that we're doing around, and then someone's either gone through it, someone knows, or someone just wants to be educated on it, and then they'll approach her. It'll be private. They don't have to, like, so no one will know they've spoke to her.
Yes.
She might be able to help them, or they'll say, yeah, put me down, I'll come as well.
But I was just thinking on that.
Personal works.
Personal voice. And you've got that group which you do with the Health Champion Network.
Champion Network.
And
yeah.
these are representatives from different communities, isn't it?
Yeah.
Okay.
Sorry, I was just thinking about some of the videos that likes of Shazia has done before. Those invites when, say, our GPs did go to WhatsApp for invitations, and people are like, I don't know what a health check is, what's all that about? If you could have a link to... To
within the video,
what's- Yeah, you know, he sees your GP invitation, whether it is text or WhatsApp or a letter, you know, and here is a video of what it's about in different languages, and you try and click on the video, you sort of, it's just, and then it's not you're not using translation, you've got it translated once and put onto video. Could people access clarity that way for something in their language to understand what the check is all about?
Correct.
You know, have a resource like that the GPs can all access and send to
And that could be...
patients and stuff.
So to sum it up then, because we've talked about the barriers and enablers and all the solutions you're suggesting now, and I think you guys do represent those same voices which we've heard, and they're saying, yeah, yes, we're underserved, but we've got solutions, and this way. If we had to take something concrete now, and I know you're part of the commissioning landscape, but we need to talk to our ICBs, the integrated care boards. We need to talk to our commissioners, the primary care networks, secondary care, GPs. We need to get these findings. What would be those solid, and I'm not too worried if there's 10 interventions that need to happen, or one intervention or 3. What would be those readily, which you're saying, I know Idris have touched on actually using community access. We need to be doing that. What would be those bold interventions that will change this? Because remember again, we're not talking about, you nicely put it as a healthy heart checks. We're not talking about the mandated service only. We're talking about that prevention agenda to say, what will stimulate people to go get a health check at least once a year for those who are at high risk, or those who have been identified every 5 years within the NHS health check. But overall, what are the interventions that you could suggest that we can take on and then work on co-design and then test? What would be those interventions?
I think a lot of it's removing the fear factor, and also so that as Shazia was saying, for some of the communities to be seen to be walking into a health centre that's labelled, you know, cancer screening or something, it's putting a different spin on it, that it's actually preventing needing those, and it's just the norm to do preventative stuff, and it doesn't mean you're ill with something. It's making sure that people realise the benefits of just getting the blood pressure done on a regular basis and things like that, so that it'll become a really good reading, and then you know if things change in the future, you know that that's not the norm for you.
Yeah.
You've got a baseline. So, but practical interventions, it could be that we train up some of our community champions in our community venues to do basic blood pressure checks and make it the norm that we have people here who are trained to do that. I mean, you mentioned some of the, it's about the GPs that are here from overseas, etc. They're really keen to do that sort of thing. But we have health champions who came to us recently through a different pot of funding and saying, we'd be quite happy to use some funding to buy blood pressure checks if we had the proper training and cholesterol checks and things like that. And there's pieces of work in different parts of the country that we can learn from. You'll know through like the work of HSN and Becky James and stuff. There's stuff going on in other communities where they've adopted that model of training your normal health champions and community champions to be in a position to offer basic blood pressure checks. The only thing there is we've got to get the GPs on board to make sure that they're aware that people will be coming to them because they've had a community check that's raised their concerns. But that's where you need that friendly face. So you need a good relationship to say, I've had this blood pressure check in the community and they told me to bring you this because we've already perhaps said to local GPs, we're doing some community checks.
Yeah.
If you see this label, it says, I've had a check up a health champion.
Trusted.
They've sent me your way. Yeah, and you've got to maybe have that front face at the GP practice, not go, what community
Then
check?
how
But you need them to be
long
on
it's going to
board.
take you to get to the GP?
Yeah, I know.
Like, I sometimes think I wish, like, we would love it if they, you know, they could do these child checks, for example, at No Fitness, because we have so many women.
Yeah.
And, you know, but then it's that barrier you said, what happens getting to the GP? But, like, people that come to you, there's so many things that, like, they'll come in and they'll get anything done. Like, they want to get this done, because, like, you know, but it's,
So the ownership is there.
yeah.
Another thing, you know, when you say translation and everything, am I right in saying you have to have an interpreter and you can't take a family member with you to most of these doctor's appointments and hospital appointments? Because before you could, and
I
we used
think-
to be comfortable, our parents used to be comfortable with us going along with them.
I thought you could take a family member, but I don't work on the GP commissioning side. I could ask
Because
my
some
colleagues.
hospital appointments, they don't allow a relative, do they?
And that could be something that we need to investigate
Yeah.
because you are right. For translation, I know being you involved, you have to have what is the word? A recognized translation service that works with a particular practice or a GP. But at the same time,
The loved one's going to know.
loved ones who are
Yeah, he's going to explain it better.
Absolutely.
Give them that support as well, isn't it?
Because obviously they'll be seeing what whoever it is they're taking in, what they're going through and what their symptoms are better explained.
But the flip side of it, because I run an interpreting and translation business for a number of years, there is always the risk factor that the patient may not feel comfortable having
it's
their family
something
members,
sensitive.
and because it is quite a personal information. But also there is the risk of misinterpreting
Yes.
and quality assurance.
Yeah.
And if anything goes wrong, who has the insurance?
Liability.
Liability. Liability is the right word.
Yeah.
But having said that, I don't think there is a consensus understanding whether you can bring or not bring.
Okay.
It has always been a gray area, depending which health service you wanted to go to.
Because I think I'd be more comfortable knowing that I've gone and I've told them exactly what's wrong with whoever it is I'm taking, and it's been dealt with, because I had to do it with my husband.
Yeah,
And
that's
he can
right.
Speak English.
Yeah, no, absolutely. But I think, that gray area needs to be clarified, whether, because some health institutions encourage you to bring your family member
Yeah.
to do for them,
Yeah.
but are they doing it so that it costs them less in terms of money and less hassle, administrative arrangements, or are they doing it because they are not aware that is a legal duty? We are not sure. So that gray area does not serve good for the patient.
Okay.
Because if they are unsure, then they are unsure. I have also seen, from my long experience of doing that interpreting section, some health centers use it as a mechanism to push you back.
Okay.
And that is one of the points that was saying that discriminatory.
Yes.
Because when you go, and I've seen it particularly with my Middle Eastern Bedouin clients, when a child or a family member, because they simply think that they are a hard job. And I must admit, it is that awful, and you can imagine how that feels. They have been pushed back several times because the GP surgery, particular GP surgery that I raised a serious concern against, they think that tribe, and it is that bad, that language, they create the more problems in the surgery. So they have been pushing them back about 7 times to get them registered in the GP surgery. So they were using it as, and they were saying, oh, no, we can't find an interpreter. So just to reply to your, some people do it because they are not fully aware about their legal duties. Others use it as a mechanism to discriminate specific individuals. And these are some of the realities that we can't really escape. And I think that whether you can suggest a solution towards that issue, whether it is cultural competence, whether it goes way beyond sacking someone, is a different thing.
It is a different
But
thing,
I think like there definitely needs to be some work done at that reception level. There's times I've been stood there, and I very rarely go, but when I've been stood there and I've watched, I've just spoke to somebody next to me.
yeah.
And
That
then
was
when I've
articulated.
gone and spoke to them, they spoke to me in a different manner, and I've looked and thought, I can't believe you've just done that. And there's times I've just intervened because I'm cheeky, and I've said, who do you think you're talking to? And I've had to intervene for other people because I couldn't believe they were speaking to somebody like that.
Absolutely.
And it's just like, and it is
Just the
certain
language,
surgeries,
it
isn't it?
does
Does
that
happen.
do it, and you think, like, my goodness, just because that person's got a headscarf on, she's no different
Yeah.
to me.
Yeah.
But you're speaking to her in a different manner that you've just spoke to me.
And it goes right back to what Ben said at the beginning about one bad experience. You're
Yeah.
setting,
Then
you're going
prevents
for a
you.
voluntary
Yeah.
check, are you? You know.
On the translation thing, the other thing I sometimes find is, like, with the translations, they need to be in a way that people can understand it. So
Correct.
I can speak Urdu, I can read and write Urdu.
Yeah.
And I'm sure you can. But sometimes when I see things written and I think, huh?
Does it mean?
It doesn't mean anything to me. And I'm thinking, I'm sure I can read Urdu, but I cannot understand that. And when they're speaking, it's done in, for example, Shakespeare, to me, Shakespeare version of English.
Yes,
And you're
yes.
just like,
I
get
don't-
that. You find that, don't you?
Yes.
But it needs to be done in the form that people can understand.
No.
Because not everybody is literate.
That has been really captured in some
Yeah.
of the findings there, and say the accuracy and the trustworthiness of that. Some spoke a bit of English, and they were saying, I wanted to challenge what the translator was saying. Yeah. So I think now we're going to recap, and I really want to give very, very briefly space for every one of you to just your final words, what you think and what the direction is to be. But before I do that, a very, very quick one was around the question around, if we do outreach, who do you think are the key stakeholders that need to be part of that outreach team? Because they're saying, not only for cultural competence, but if you go to this venue, this would work. Is there any reflection in terms of who needs to be part of that outreach team? Because we've approached other areas, other stakeholders like Middlesbrough Football Club, with Sarah Slater, and they're very clear to say, we're on the bus, and we're actually having upskilling sessions with their team to make sure that clinically they know what they're doing, but they say going into communities is another thing. So is there any quick reflections of, if we've got a community outreach approach, who should be part of that team?
I would say the learning we got from COVID is massive for us, isn't it, Idris? Because it was through people like Idris and all the community contacts we got through the health champions, that approach was a success. So those
we can
key
learn
figures
from
from
that.
COVID, can you help us with this topic? I think with COVID it was, we really had people stepping up because it was so unanticipated. It was just a huge, scary time for everybody, that people that might have been on the outskirts of engaging previously really stepped up, and we've built on those relationships. Whether they have the time or the capacity to do that again we will find out, but we made such great contacts through that. We could go to them for cancer, for CVD, and it's just making sure that they have the feel supported to do that, and that might be where some of your incentives come in, if that's an issue. But
that's
the great contacts that we had through COVID, you could almost do with repeating that approach. And again, as Idris said before, using those venues, using those contacts, the faith leaders and things like that, to support your messaging. So there's work there and contacts there that we could potentially build on.
Excellent.
Can I just quickly say, I don't think it is very complicated for us to pitch where we should go.
Okay.
I think the baseline for me and for anyone who think rightly really is, where do people go?
Okay.
That's the question.
Yeah.
Where do people go? If they go to church, then I think that church has to be a stakeholder.
Yeah.
If they go for fitness, then, so it is, if they go for food, if they go for clothing, so it has to be where people go. So these are the spaces, these are the individuals, these are the institutions, where do normally people go?
Yeah.
So when they go for other places of interest, it might well be a hair salon.
Yeah.
Could be a bingo hall.
It could be a bingo hall.
Yeah.
So you did that approach.
Those are places where people go for their own, for other interest.
Yeah.
And I think we can take that long list and then try to see if there is
out.
duplication, if there is
Correct.
things. But I think naturally that should be the potential stakeholders.
You're
have
right, because
them in the
there was
conversation.
those initiative you were involved with, I think the other around cancer, where hair salon, where people, you know, were educated, the community champions were talking to their clients when they're getting there. Not so much for me and Idris with no hair, but those who are going to hair salons, you know, you get that. So I think settings is very important. So I think I'm just going to go around and you don't feel obliged to have your own final words, but I just wanted to give you an opportunity to say, was this helpful, the engagement which we did, the findings, are they, you know, helpful, and what do you need, what are your next steps? So I'll go around, Idris, what do you think, what are the next steps, and how can we keep this agenda right at the forefront?
Yeah, from my perspective, I think the links that we made during the consultation sessions, I think those need to be, we need to build upon those links and utilise those communities and contacts that we have. But you mentioned about, you know, salons, and I think barbers, especially for men, I think that they're a great way of engaging men in discussions about health and well-being.
Absolutely.
So I think that's something that we can potentially build upon.
Oh, thank you. Katrina?
I think that there's a lot going on through obviously through this programme, through the regional work around CVD. The health champions models developing all the time, so we're in a good position to move forward with anything that we think are the next steps. And there's learning there, so it's all pretty positive from our perspective. It's just making sure that we implement what people have suggested.
Yeah. And that's the feedback loop, isn't it? Thank you for that. Billy?
I think what we have seen over the years is reports such as this one. They get diluted and diluted and diluted.
Correct,
and
yes.
trimmed and trimmed and trimmed, and they change their shape eventually. So I think keeping the quality of it as it is.
Findings.
Yes, yeah, keeping the quality, and then not undermining some of the suggestions that has been.
Correct.
Okay, and then just implementing those would be a really good next step for me.
It's interesting. It seems as if you were in my sessions, because the people were saying that, how do we trust what we've said to be articulated in your interventions? So it is a very good point. And very, Shazia?
And I think going on from that, like feedback back to, like, for example, to them as well, because we are constantly, like, you know, requesting the women to join different focus groups, and we say, look, your voice is being heard.
Yes.
But, you know, it'd be really good to go back and say, well, actually, your voice was heard, and this is the outcome of it. And sometimes, even if, you know, I know it's difficult to, but if someone could come back and speak to them again and, you know, give them something, I just feel like it just then helps us as providers to then say, look, this is what happened on this one.
This is what you said. This is what is happening as a result.
As a result of that.
Yeah.
That'd be, like, really good for us.
Yeah. The intention for us is to share this video online.
That's
so
really good,
that'll be. But beyond that, we then want to synthesize what we've talked about today, propose those with a co-designed approach, go to our commissioners and say, this was what came out and this is what is happening. And like you say, have that opportunity to say, yeah, it might not be exactly what you thought it would be, but this is what has come out of what you said. So that's it.
Yeah.
Nusrat?
Small scale, keep talking about it. Like you said, women drop their kids off in schools as well. You could have someone speak to them there. The men go to pray on a Friday. Big scale, it's like, if they do go and get the checks, the access, how they can go and access and how it can, like, be treated straight away and not be left on the back burner.
I like how you put it across small scale and big scale, and that really came out of every working group. They had those solutions to say, we want to do this, this can happen, but on a big scale, which is public health, really population approach, we need to do it that way. I think it sums up nicely, and I cannot ignore this quote which I got from the research there. One person said, if you want to go fast, go alone. Run, go alone in any race. But if you want to go further, you know, run with everyone who you've got. You get that backing, you get that support. So I think this is exactly what we're saying. People individually have mentioned what they would want to see, but collectively, I think that voice is louder, is a lot clearer. And I do think this can reverberate nationally, because small pockets of people who've got same ideas, if that idea is put together, it can be as loud and resounding as it should be. But I do like what you've also mentioned about that feedback, and we should have that opportunity to say, this is what is happening as a result. And they've got the opportunity to say, actually, still it's not good enough, or actually this is what we were looking for.
I just asked Joe, obviously we've had a lot of discussions today about issues in GP surgeries. What's our route into the GP practices then to give the feedback from the research?
So from this, after we've done the synthesis, we will go back to the Integrated Care Board,
Yeah, I see.
who are part of the InHIP project.
Yeah, okay.
They need to take it on the chin in terms of the feedback and especially what affects their capacity and capability. And I know there was some staff from NHS England who had vested interest and who had actually said, you might come up with solutions which changes the way we work or which impacts on our capacity, but they're not putting a barrier to say we don't want to hear it. They say we want to hear it. So I think to answer your question there, we will be able to take it back through the AHSN directors, back to the ICB and nationally to say, is there a stencil to change the practice here? No, I'd just like to thank you guys for your contribution, and as we've said, this will be a resource which we are more than happy to be shared through all your channels. And again, for the communities to know that we've actually concluded this with a feedback loop. So thank you for your time.